Good afternoon, everyone. How are we all today? Woohoo, good. My name's Brenda Roth. I'm the Public Programs Coordinator here at the Nantucket Historical Association, and I want to thank you for coming to another installment of our Food for Thought series for spring of 2016. As always, we would like to recognize that the Food for Thought program series is made possible by the MS Worthington Foundation, and that media sponsorship is generously provided by Novation Media. If everyone could please take a moment to silence your cell phones, that would be greatly appreciated. And on to the first of our two speakers today, Jason Graziadei of the Nantucket Cottage Hospital. Jason is the Public Information Officer and is leading communications for its capital campaign for the new hospital. Prior to joining the Nantucket Cottage Hospital, Jason spent nearly 10 years covering the island for the Enquirer and Mirror. So if everyone could please give a warm round of applause for Jason for today's Food for Thought.
All right, thanks, Brian. And I want to welcome another speaker from the hospital, Brenda Johnson. And Brenda can introduce herself. She was around at the hospital for a few years, right, Brenda?
Speaker to go. Yeah, now it's gone. So for those of you who don't know me, I'm from Nantucket, and I started working at Nantucket Cottage Hospital in 1975 as a nurse. I've worked in the emergency room, in the operating room, and the reason we're telling you this is so it gives you an idea of why I might be involved in this project so intimately. I've worked in OB. I did dialysis before we had a dialysis unit. I've run home care, been the compliance and privacy officer, patient satisfaction. I chair the patient family advisory councils that we have two of. And the other thing I did was I was the interim manager for radiology. So there isn't anything at the hospital that I haven't done. And that's why I'm having so much fun doing this project. So more to come.
And Brenda's the clinical program director for the new hospital. So a big part of the past and a big part of the future. And the topic of our lecture today is the future of the hospital and what we're doing with the new hospital. But before we wanted to jump into that, I just want to thank the Historical Association for having us here today, and all of you for taking some time out of your day to come hear our story. And the topic is the future, but since we are in the NHA, we wanted to touch a little bit on the past and go into the history of the hospital just a little bit to give us a sense of where we're going in the context of where we've been. So some of you might know the hospital was founded in 1911. Dr. John S. Grouard and Dr. Benjamin Sharp, it was their vision to found Nantucket Cottage Hospital. And this quote that you see behind me, I included it here. It's on our website. I thought it was a really interesting quote. To conserve human life on this isolated island, it is imperative that the conditions under which medicine and surgery are practiced must be superseded by more modern ones. So that was very pertinent back then in 1911, still pertinent today as we look forward to the new hospital. So that was their vision in 1911. It was founded, but at the time, they didn't have a home. There was no place on the island for the hospital to go. So that was sort of the first order of business for the hospital's endowment committee. The following year in 1912, the Hospital Endowment Committee purchased the old Charles Esty homestead on Westchester Street for the whopping total of $6,000. And again, I thought it was interesting. Again, even back then, there was objections from neighbors about the siting of the hospital on Westchester Street. So even 100 years ago, figuring out where a hospital should go was not an easy thing. It was controversial. It was a difficult thing to try to find the right site for the hospital. So that Westchester Street was the home of the Nantucket Cottage Hospital for over 40 years, and the NHA has some really great photographs, old photographs in their archive, which I included some here in the presentation just to show you. But you can go through there on their online archive and see some of these group of portrait of some of the nurses in the 1920s. And again, this was the home for the hospital for over 40 years. Here's the operating room. Kind of looks like something out of Frankenstein now. But so again, but that was it was in a cottage. It was not a hospital as you would think of one today. So this was supported the island for over 40 years, but got to the 1950s and the hospital leaders started looking at building a new facility, an actual real hospital, moving out of the cottage. So in July of 1953, this was the front page of the Nantucket Enquirer-Mirror announcing the campaign for the new hospital. This is the architect's drawing of the new building. So July 18th, 1953, the campaign began for the new hospital. You can see this land was given to the hospital by the town on Prospect Street, where we are now. You can see it ended up in almost the shape that the architects thought it would. It originally didn't have this wing that's on the southern end. That was not built. But this is essentially what was built. So 4 years later, after this announcement in the Enquirer-Mirror, in 1957, the hospital opened on Prospect Street. Another great photo, first baby leaving the hospital. This is a really nice image because you can see all this land back here, how empty it is back then in 1957, how different it is from what it is today. So 1957, the hospital opens. Immediately, the hospital was very busy. It was built on an inpatient model. You have people who are there for weeks, months, and it was so busy, it became clear immediately that it wasn't big enough. And 10 years later, they broke ground on the new hospital wing, which is the southern wing of the hospital, closest to Vesper Lane. So here you see Sandy Craig and the hospital leaders breaking ground on the new wing of the hospital. Here's a nice photo of it under construction there. And that was completed in 1968. Throughout the hospital's time, throughout all these years, the expansion, the addition, the new hospital, it was all supported by the community. It was all funded and supported by the generous donations of the community. So what did that look like? In the early times, this was the hospital fetes. So people would dress up in costumes and have parades. And if you look back in the archives of the Enquirer-Mirror, there's some really great pictures of people and the celebration of the hospital. And that tradition of community support continues today. Doesn't necessarily look like that anymore, but we do have really strong community support. So these are some of the things that really allow the hospital to exist. You guys all know the Boston Pops every August. The NCH Fund is our annual appeal. The Swing is a golf tournament that we do every September. The Thrift Shop right over on India Street, amazing, 86 years that they've been there and contributing. The first donation that they did 86 years ago was $600 to the hospital. Just this past year, they had another record-breaking season, contributed over $300,000 to the hospital, selling used gifts, donations from the community that people bring down to the thrift shop. So it's really an amazing source of support. And this year's donation, part of it is going towards the building of the new hospital. Another half was for new equipment. And also Swim Across America is another really strong new program that supports the cancer care program at the hospital. So over the years, all this support has funded new services, expansions. These are just some of the highlights. The emergency room was expanded and grew in 1983 and again in 1999. 1983 was also the first year we had a first laparoscope in the OR. The chemotherapy program at the hospital began in 1991, spearheaded by Charlene Chadwick. And that's really grown with the help of the Swim Across America and our partnership with Mass General Cancer Center. In 2000, the labor and delivery moved from the sort of north end of the hospital to the birthplace where it is now towards Vesper Lane. And that increased in size and capability. The first telemedicine program in 2002. And these are, there's obviously lots more things that have happened over the years, but this is just some highlights. And in 2007, Nantucket Cottage Hospital affiliated with Mass General. So this kind of carries us forward to 5 years ago in 2010, when the hospital really faced a lot of challenges. It really ran into a rough patch, as many different rural hospitals have. This was the headline in August 2010 in the Enquirer-Mirror, Hospital at a Crossroads. And the article really talked about some of the challenges that the hospital was facing that put it in real trouble. It really looked into things, it was if you've heard Margot Hartman, Dr. Hartman talk about this in other forums, she talks about a perfect storm, declining volume, lower reimbursements from the government, a failing building. You know, the building was built in 1957. You probably remember the kitchen drains basically disintegrating. We had to shut down the kitchen for a long stretch there, and that we had to stop doing things like the Meals on Wheels and bring in catered meals. The plumbing over to the physicians' offices went. And it created an environment in which the hospital had very low morale amongst its employees. And the budget-wise, the hospital was losing millions of dollars every year. And again, this wasn't unique to Nantucket Cottage Hospital. This was a similar situation for rural hospitals all over the country. This is a headline from 2014 in USA Today, Rural Hospitals in Critical Condition. They reported 43 rural hospitals have closed since 2010. There was a recent update in Becker's Hospital Review. 673 rural hospitals in 42 states are vulnerable to shutting down. And I thought this was a quote from the USA Today story from a professor at Quinnipiac. The standalone community hospital is going the way of the dinosaur. So that it really kind of crystallizes some of the challenges that not just us, but all rural hospitals. So what did the hospital do about it? In 2010, the medical staff put forward Dr. Margot Hartman as president and CEO. She was appointed to that position, and they started what they talked about, rebuilding from the inside out. So the Board of Trustees and Dr. Hartman and her team really did some things, strategic investments in services, things that like orthopedic surgery, the oncology. We started a partnership with the Mass General Cancer Institute. We have a walk-in clinic now, a hospitalist program in which the physicians track the care of inpatients in the hospital. That's relieved a lot of the pressure on the primary care physicians who many times were reporting to the emergency department to see the patients on the inpatient floor. Really got a handle on the business end of being a hospital, the charge master, billing, and really got a handle on that part of operating in this healthcare environment. And we really engaged the community. We did a marketing study and talked to our patients and the community members and asked what are we not doing that we should be doing? That led to things like the expanding pediatric care. We now have a partnership with Briar Patch Pediatrics, board-certified pediatricians in the hospital every week. We have a new partnership with a group of emergency physicians in the emergency department. And also bringing more physicians here, specialty physicians, and allowing more people to access care on the island. So right now we have 33 specialty physicians in 24 different specialties. So that was kind of the highlights of what they did to address the sort of perfect storm that the hospital was facing. What were the results? You can see this is a big project that Brenda worked on with the Patient and Family Advisory, but we looked at the patient satisfaction. In 2010, you can see 41% was a metric that we look at called the patient's likelihood to recommend the hospital. So you can see that's almost doubled in 5 years. The hospital has operated in the black for the 4 consecutive years, which is huge. You know, what does that mean? It means we're almost break even on the operating side, but with the philanthropy, with the community support that I described earlier, all those different, the POPs and all the different fundraising, we're now, that gets us out of the red for the past 4 consecutive years, which is huge. So the goal is really to get the best of both worlds, keeping that local, small community hospital feel, that's a personal touch, but also leveraging the affiliation with Mass General. And brings us to the hospital today. We are a nonprofit hospital. We have 10 island doctors among the primary care, emergency department, and surgery. Again, as I mentioned before, 33 visiting specialists and 24 subspecialties, 250 employees, so including all the physicians, nurses, support staff, housekeeping, facilities. We are one of the largest employers on Nantucket. We have a $38 million operating budget, and you know that supports. We're open every day, 24 hours a day, the emergency department, the med-surg beds, the inpatient, and the maternity. So what does that look like in a given year? These are just some really key statistics that we've put together for our last year. So you see we've had 137 births over the last year, 137 Nantucket natives. 875 general surgeries and procedures. Our emergency department sees over 10,000 visits over the course of the year. Our physical therapy, which we recently moved to Bayberry Court, big, they have a huge amount of volume, which is one of the reasons why we moved them out of the hospital into their own dedicated facility. 30,000 physical therapy treatments. You can see some of the statistics on the imaging. So 1,200 mammography exams, 1,300 MRIs. The lab, another very, very big part of the hospital, close to 80,000 lab tests over the year. And here's some more numbers just to give you a sense of all the things that the hospital is doing. Our primary care offices see an average of 160 patients every day. We have our social services, which is a free service that we provide to the community. 1,100 families were able to apply for health insurance under the Affordable Care Act with the assistance of the Social Services Department. The infusion with cancer care and chemo has a huge increase. One thing I'd like to draw your attention to is 98% number. So 98% of the patients that come into the emergency department are seen and taken care of on Nantucket. So what does that mean? 2%, very, very small percentage actually have to be flown out of the cases that come in. So you do see that helicopter, but in terms of 10,000 to 11,000 cases that come into the emergency department, a very small percentage actually are flown off. So when that helicopter comes, it lands, it drops off the crew, goes to the airport, refuels, comes back, picks up the patient and the crew, and leaves. So you do see a lot more traffic than what it might actually is. So, and some fun statistics. Over the course of a year, we went through 2.6 million sheets of toilet paper, believe it or not. I think this number is kind of low. 4,700 cups of coffee seems kind of low to me. But again, community support. We had over 600 volunteers who helped us, whether it was the Blue Coats, at the Pops, all different programs, and our food services, 30,000 meals. So you can see there's a lot happening within the hospital. So going back to the 2010, we really addressed some of the things that the problems we were facing, the volume. We did everything we could on the business end, and it got to that final piece of the puzzle, which was the building, and what are we going to do about the building? So Dr. Hartman and her team and the trustees really looked at this, really studied, does it make sense to renovate? Does it make sense? What would it mean to retrofit the existing hospital and bring everything up to code versus building new? Where could we put the hospital? So we tried to answer this question, and they came to the conclusion that, yes, indeed, we do need a new hospital. It needs to be a new building. So the first thing we had to do was go out and talk to the community and be in a dialogue and answer the question, why do we need a new hospital? And this is a question that we've been out talking about for a couple years now. We do feel like we've answered it, but we do hear it come up, and people ask us this. But some of the primary reasons you'll see in the screen behind me. The hospital was built for an inpatient model, which again, 90% of the hospital's business now is outpatient. You have surgery, you're out, you're not staying 2 weeks or 3 weeks in the hospital anymore. You're out that day or the next day. Every space in the hospital, with the exception of our CT room, does not meet code, the Department of Public Health code. Everything is sort of grandfathered. So again, if we were to retrofit, that means it's a sort of, you'd have to create the space that meets code. We only have one functioning operating room. Again, what does that mean for care? If a woman goes into labor, that operating room has to be reserved for her in the event of a C-section. So if you have an elective surgery or something planned for that day, that's either postponed or canceled. So that sort of is another limiting factor. Privacy. Brenda, I'm sure, can speak to this better than me, but that's a big issue for our patients. It's a small community, a small town. And in this building that we have, the way it's set up, it is an issue everywhere you go. You had an MRI. If you're taken out of the emergency room, you're going through the public hallways, you're bumping into your friends and family maybe, who maybe you don't want them to know that you're getting treatment or something like that. So that's another issue that comes up. The infrastructure, which you're going to hear about in a second, is really, if I could take you into the attic of the hospital, where all the air filtration and suction and all the things that make the hospital run, we took tours of people up there before our facilities director told us not to do that anymore. And we take them up, and they would take one look and say, okay, I get it. And really, the facility, you look at the hospital from the outside, and it doesn't reflect the gold standard of care that we provide inside. So To help us answer this question, we put together a little video, which I'm going to show you. And thankfully, Dr. Hartman is featured in it. She couldn't be here today. She says hi to everyone. But she is featured in this video, so I'm going to cue this up and play this for you now.
In 1957, this was a brand new building, a modern hospital that replaced the original cottage hospital, which had once been a private home. One of the first patients to be treated here was the station agent of the Steamship Authority. He was recovering from a heart attack. That was long enough ago that the ferries were actually powered by steam. Think for a moment about the treatment he received then and the treatment he would receive today. Medicine changes fast, and tomorrow it will change even faster. I think we have the most extraordinary opportunity to do something for this island that will serve the essence of its wellness for generations. It's just that simple and that huge. You know, it's one thing to see a nicely painted wall, and it does matter to us very much to give our patients and our staff the best possible experience they can have in the years that remain for us to work in this building. But we're living on borrowed time. Behind these walls, the infrastructure, the electronics, the plumbing, the ventilation, the oxygen and air and suction, and all of the things that make a hospital, technically a hospital, are struggling. Our pharmacy is about a quarter of the size that it should be for the amount of work that it does. We are one of the few small hospitals that are College of American Pathology approved laboratory. But each time the College of American Pathology comes here and accredits us, they comment on how small our lab is. And it's one of the things that they bring our attention to every time. Our one operating room was built in 1957 when regulatory standards were very different. Currently, it would be, for the Department of Public Health, the size of a minor procedure room. But it's our one and only operating room. If we had 2 ORs and they were properly sized, we could keep more patients on island and do more appropriate surgeries than we can even imagine doing now. When I think of a new building, it's just a hollow shell if we don't have robust services and a quality staff that's supported to bring their best work and that can adjust to changing times. And that's really what people are investing in. Our ability to adapt and bring gold standard medicine in a local way.
So I hope that kind of explains the rationale. Why do we need a new hospital? And when we answer that question for ourselves and the community, we started the process of how are we going to do this? Where can we build a new hospital? So that started the site selection process. We originally started out looking at the current site. This is the hospital here. This is Prospect Street, and Vesper Lane would run right here. So, and looking at building it in this area. And that was the start of the plan that we originally had. And then we said, with all the disruption that this is going to cause, trying to keep the current hospital open while we build on the current site, it behooves us to look elsewhere and to look to see, is there a better site on the island? We looked at Wyers Valley off of Milestone. We looked at Mill Hill, Old South Road sites, on Sun Island Road out by the airport. We went through this for 2 years, and it was controversial and painful. But I think with a project of this size and of this scope, it was inevitable that figuring out where it should go was going to be kind of a messy process. And we listened carefully to the feedback that we got from the community, and we heard a message loud and clear that was to figure out a way to make it work on the current site and figure out a way to make it happen where you guys are and don't try to move the hospital. So where did that lead us? That led us to the 2015 annual town meeting when we went forward with Article 70, which was a zoning proposal, which was really the key to allowing us to move forward on the existing hospital site. So Article 70 was approved unanimously. Thank you for anyone who voted for it. And what did it do? It rezoned the area around the hospital and Gwen Village, which has Coast Guard housing, as well as UMass Boston property and Nantucket Cottage Hospital property here, which is also where Family and Children's is. But what it really did was created this hospital overlay district. It defined the uses. What is a hospital? That was never in the zoning code before. And most importantly, it gave us the flexibility to operate on this site in terms of the height of a new building, parking, setbacks, ground cover, and required that any new hospital gets a major site plan review by the planning board. So that was unanimously approved and sort of gave us the ability to move forward with the project, and that was April 2015. So what have we been doing for the past year? After town meeting, we formed a strategic planning committee of hospital leaders and trustees and started really crunching the numbers for the hospital. What should it, first of all, on the site, where should it go on the site? We looked at 5 different options of that, including a partial reuse of the existing hospital with a new building. Looked at 31 different criteria for those 5 options, looking at what would be the patient experience in each option, staff efficiency, minimizing costs and disruptions. And as we went forward with that and sort of narrowed down our choice of the location on the site, we started to engage hospital staff, community members in the design process, including our Patient and Family Advisory Council, we call it PFAC, and getting input from the people who are going to be working in the space, the people who are going to be receiving care in this space. And it's brought us to the point where we are today, where we are close to finalizing our plans. Now, what I'm about to show you is sort of a snapshot of where we are in this process. It's still evolving. It's not finished yet, so this is a sort of preliminary look of where we're at. We're coming to the end, but we're not there yet. So what we have designed is a 2-story hospital that will replace the existing, and I'll show you, what this might look like on the site. But this is a rendering of what the main entrance might look like. It would be about a 105,000 square foot building. Now, that sounds really big, and it is. It's partly a reason because we're retrofitting. The hospital has to be built to code. But if you think about it in the context of the space we currently utilize in the hospital, all the physician offices, all the outbuildings, it's roughly 10% larger than what we have now. So this is a look at the front entrance of what it could look like. This would be the Vesper Road elevation. So again, I'll show you where on the site how this will look. But again, you can see the attempt to break this up and not make it look like one big imposing structure, a big wall, and trying to make it look with different massing broken up. And now we're going to just show you just a sort, again, preliminary. This is where we're standing now. These things are still in flux a little bit as we go through the process, but this is where Brenda has done a lot of work working with the clinical departments and figuring out where things should go in the hospital, what makes sense to be next to each other, what should be on the first floor, what should be on the second floor. So I'll turn this over to you, Brenda, and you can talk a little bit about the process that you've gone through as clinical program director.
How do I use this?
Just hit that button.
Which button?
There you go.
Perfect. So I'm not a very technology person when it comes to this. So when I first started, Dr. Hartman asked me if I would take this project on in December, January, and I thought, what fun, because obviously I've worked at the hospital for going into 43 years, and actually I was a volunteer there when I was 12 years old, and only David Worth knows how old I am, so we won't go there. But what we did was we readjusted all of the groups, and I decided to take the groups that work in the different areas and then anybody that worked in the adjacency next to them, because of course we all have to work together and flow is important. And we added some more people. We added the materials management people. We added the physicians, obviously, because this is so important to them, the IT people, the infection control people. So this has been a huge undertaking for the entire staff. People on the street have told me, what about this? Our patient family advisory councils have brought us information. Our patient experience task force have brought us information. I go up to patients on the floor and say, what's important to you? What made your experience the best? And then, of course, being the privacy officer and living here forever and knowing a lot of people, we realized that privacy was we know it's so critical. And I think what's exciting is this is the first time that we have built a building with the patient as the major player in the entire thing. So the patient's journey through the organization and then the staff. So that's been kind of a nice change. So what we did was we took the plan and we wanted to identify who needs to be where near each other. And we figured out that the emergency room was going to be here, so the emergency room's here, and you'll enter to the emergency room from the that dirt road, which will be, not dirt, but towards the historic cemetery. Do you know where I'm talking about? Okay. So this is the emergency room. We've gone, and Jason's got it in his slide, from 7 spaces and 2 spaces in the hallway to 12 rooms to be able to treat patients. And we've worked with a couple of these rooms being able to swing back and forth from observation status because, as Jason said, we're not an inpatient healthcare system anymore. Dr. Lund can probably remember those days too. So when I came here in 1975, we had 50 patients on the floor, and the patients were on the floor, med-surg floor, because maybe the maid was taking the day off and they wanted a place to put their the person who they worked for, or you were having a colonoscopy and you needed to come into the hospital for a 2-day prep, or you were having a gallbladder out and it took 2 weeks to get recovered from a gallbladder. Those days are gone. DRGs have changed how we do medicine. They tell us who can be in, who can be out, and yourselves, your insurances are changing what they'll pay for nowadays. Don't you know that? Is that true? Yeah. And instead of getting more, they're cutting back and giving you less. Would you agree with that? Yeah. So that's the way healthcare is going towards outpatient. But we still have a lot of patients that are sick and need to be in the hospital. So we decided that from an adjacency perspective and a staffing perspective, sometimes we don't even have anybody on the med-surg floor. Sometimes we don't. And sometimes those days the emergency room's very busy. So why can't we put them adjacent to each other and share the staff? And so by putting them in the same location, that makes it work. So we can share staff. Then we decided, okay, the emergency room, what's important besides the med-surg floor being near the emergency room? Well, what's important is that we can get those patients to radiology in a quick straight line. So we figured out the adjacency and we moved radiology or imaging to right next to the emergency room. Again, following the patient. I'm a patient, I'm walking through, I've come in multiple trauma, we've got to get this person to x-ray, how are we going to do it? Well, we don't want to go from here to here to here to here, we want to go a straight shot. So we've worked on that. Our MRI will still be outside, but we'll have it such that you'll be able to walk straight into it. You're not going to feel like you're walking outside and down the stairs and up the stairs. So that will be contingent on that. We decided that we needed to also look at the efficiency of our staff. So how are they going to get their supplies and bring them to the rest of the hospital? So we have a loading dock here, and our supplies will easily function in the back hallways so that we're not interrupting patient flow. We have a respite room. Patients have said that they would like a respite room. It's important when they have, somebody who's at the end of their life and they need some quiet meditative space, or they might need a clergy person to be talking to them, or just private family space. We have a respite room right here, and it'll look out over a serenity garden that was so important to Nancy Minus. For those of you who remember her, she was So for those of you who remember Nancy Minus, she was one of the ones that started palliative care. Gussie, I think that's correct, right? Isn't that correct? About Nancy Minus? Okay. So there'll be a reflective garden here. The other thing that was so important in designing this building is light. When we met with the community, they said they wanted light, they wanted it to be warm and welcoming. And so every single design, besides taking the patient through the walk, have been, where's the light? So you'll notice that this is the west end, looking out over that land.
Do you want to go go to that slide that shows it.
Oh, yeah, can you do that? Okay, so here's that, that open land that's quite lovely, and here's the side where the patients are going to be. So the patients get to look out over this field. You'll notice that over here, it's light, and this is where the physician space is. And, you know, quite frankly, when you're going to go see a doctor, you're not sitting there looking out the window, right? You're going to see the doctor. But in the emergency room, in the waiting area, again, you're going to be looking out over a garden in some lovely space. The respite room looks out over the garden. The waiting room here for the patients looks out into a little garden space, and of course, the parking lot. And then this is the walk-in care, this is the primary care physician space, and you'll come in that way to go to the primary care physician space. Do you want to go to the next slide?
Yeah.
Oh, and the lab is right here. In the lab, we've increased that, so we have an EKG room, which will be nice, because, you know, when you're getting your lab done and you have to have an EKG, well, now you'll have a more private room to be able to do that in, so that's quite lovely. Pharmacy will be down here too, because again, the synergy between pharmacy and med-surg and ED is pretty strong, and they're used to consult all the time.
Right.
Do we have another floor? The second floor, again, this is just a snapshot, but when you come up the second floor, and there's an elevator and a stairway, you're going to go into the OB suite. One of the things that was so critical with the OB was that we have it in close proximity to the operating room. A third of our patients that come in to have babies usually end up having C-sections. For one reason is because we don't do vaginal births after cesareans. The repeat C-sections are repeat C-sections. So when people come in after they've had a C-section before, we know they're going to have a C-section again. So there's a fair amount of people that do that. Their choice, I mean, they don't have to have their babies here, but they choose to. And so we have about 137, 146 deliveries a year. And so we have 3 LDRP rooms, a postpartum room, a tub room. The PFAC, the pediatric PFAC, was very strong in saying that they wanted a tub room to labor in. And we have increased our triage space, which is important. We've increased the nursery space. So, and it's right down the hallway to the operating room. The operating room, because of that proximity, is now in a racetrack. And this design is a little bit off, but it's a racetrack design. And again, we flipped it because we looked at it and said, wait a minute, we've got infusion patients, we've got dialysis patients, and they're not looking out, taking advantage of the view. So that in the plans is actually right here, and the infusion people do have a lovely view, and they have private space. So we've gone from the 2 rooms, the 2 chairs in the chemo room that are separated by a curtain to 5 rooms, because one of our patients said, you know what, I want a room. I want to be able to have my husband, I want my Charlene Thurston to come in and talk to me, or the nutritionist, and I want it to be private, and I want it to be comfortable. So we said, well, that's the answer. And truly, when the architect was talking about light or no light, curtains or no curtains, I said, forget about that. Called the patient in, and they said, oh no, I want a room, I want it private, I want it comfortable, and I don't care about the lights. So we were able to get all of it. We got the lights, we got the room, we got the privacy. So we thought we were in pretty good shape. And plus, we added 3 more stations to that. Dialysis, presently we have 2 chairs. We will have 3. We'll have 1 room that can be used for isolation, and we have the 2 dialysis chairs, being mindful of trying to make a little bit of a wall for privacy, at the same time affording the nurse the opportunity to be able to work in that space and visualize both patients at the same time, which is what she needs to do. So, our improvements, because people want to know, well, what's different? Well, what's different is, as I said, the emergency room is expanding to 12 rooms. 2 of them are trauma. We have the ability to accommodate 2 ambulances at the same time. We have the 2 observation rooms that can swing both ways to the med-surg floor and the floor. And we will probably have a discharge room. The maternity is what I was talking about. We have 3 labor rooms, 1 postpartum, an isolation nursery, a regular nursery, a triage room with 2 beds, that's new, and a tub room, because they do labor in those beds. Apparently, I was told that people actually try to make reservations for it when they come in. And unfortunately, it's a first come, first serve kind of deal. Infusion, again, I just told you about that, and the OR suite. For those of you who've had the pleasure of having a colonoscopy, you know that room that you've been going into, the little room with a, right? So that was 2 chairs, and we've certainly tried to accommodate people's privacy because it's so important. We are now going to 7 rooms that are individual rooms, and you'll do your pre-op, your recovery, your post-op, and your discharge from those spaces. So that increases privacy significantly. We also have added, in addition to the operating room, a C-section OR room that can be reserved just for C-section ORs, and endoscopy room. In all of these spaces, we can use in the case of an emergency. That's one thing people want to know. What are we going to do in an emergency? How are we going to put patients in spaces? Well, we have about 32 spaces now that we can actually put patients in laying down if we were to have some sort of emergency, multiple trauma type thing. Okay.
Next slide. And again, showing you this to give you some perspective on the site. This is Vesper Lane, this is Prospect, and why does it take this shape? The current hospital is this site. All the construction, everything that's going to happen, the current hospital will have to stay open while construction is happening. So there was very sort of small footprint on the site where this building could go, where it would make sense, and where we could keep the current hospital operating while we're building. But again, some of the nice things is with the helicopter right adjacent to the emergency department. Right now, if you're leaving on a helicopter, you go through the building, through the public hallways, into a parking lot, and then to the helicopter pad. When the helicopter comes, we have to shut down the parking lot. All our facilities staff have to run out, drop what they're doing, secure the parking lot, check any trucks for anything in a flatbed that could get sucked up into the rotors. So it's a really kind of a production that it works, but it doesn't make a lot of sense, and it's sort of evolved over the years into that situation. So you have a helipad right adjacent to the operating room. Our housing, all the hospital, not all of it, but a good amount of it is right here, which is why the hospital we want to keep that intact, because as everyone knows, the housing crisis that we're dealing with now has impacted the hospital significantly. So we want to keep that housing intact. So there was really only a few places where this building could go, and allowing for the delivery of supplies, and having this area where we can pull in and have deliveries there that's not in the patient parking area. So again, this is a preliminary look. It's not going to end up like this, but we wanted to give you a sense of the progress that we've made towards realizing what this is going to look like on the site, and the direction that we're headed in. And again, Brenda touched on this question, which is what we're trying to answer now, and what people are asking us. What's going to be better? What's going to be different about the new hospital? Again, I think the patient experience is going to be transformed in a way that we're able to keep that sort of community hospital feel, but while we're also able to enhance privacy and safety. Brenda talked about the operating room. Having these multifunction rooms. Sometimes our emergency department is full, but the inpatient beds are not. Sometimes the inpatient beds are overflowing and they need additional room on the med-surg floor. Sometimes the infusion is full and they need another. So having these rooms that can serve different functions and are right next to each other, I think will serve patients better and maximize our efficiency for staff. The clinical space for ambulatory specialties. So that's space is going to increase. Right now, we only have limited space to bring in specialty physicians. Sometimes they can't come on the days because we've booked all the rooms full. So increasing that space will provide more opportunities for specialty physicians to come to Nantucket. People can get the care they need here. When I say unified primary care, on this first floor here, this whole space, which is a large space in the new hospital, is for the physician clinic. So right now, the physician offices are all kind of spaced out. This brings them all together with the specialists. Not all of them. We still have the space over at Sherburne Commons where we have a primary care office, but brings a lot of these people together. You can work collaboratively as a team. So they will be sharing that space. And the building will be able to incorporate new technology throughout. So we talked a little bit about telemedicine. Every room will be telemedicine capable. And really we'll be able to maximize that technology for patients. what are some of the programs and services we're going to have. So we've talked about it a little bit, and this isn't a comprehensive list, but the foundation of the hospital: emergency care, primary care, surgery. With the new walk-in care will be also, and all the different specialties that we have: pediatrics, infusion, cancer care. So for a small community hospital, I think this is a pretty good breadth of services that are available now and will be enhanced and maximized in the new building. So another question that we've been talking about a lot: how are we going to pay for this? How is it being funded? That, as I've talked about before, the community support. This project is not going to be funded with any taxpayer money. It's all through private donations. So you can see here our campaign goal for the hospital is $89 million. Now, of that number, about $60 million is for the new construction. The rest of it is contingencies, site costs, and taking down the old building when the new one is ready. And so we're about $60 million in pledges and commitments towards that goal right now, which we made amazing progress without even being able to show people what it's going to look like. Now we were talking about our vision for the new building. Now we are able to show people what this new building might look like. So here we threw in a little picture of the last capital campaign. Sandy Craig and Phil Murray were watching Betsy fill up the thermometer in front of the Pacific National Bank. We're hoping to do something similar to that. Again, this has been a tradition to have the thermometer for the hospital on the Pacific Bank to measure our progress. And a couple facts about the fundraising effort so far. Again, as I mentioned, no taxpayer funds. As of March 1st, we're close to $60 million in gifts and pledges that we've received. 40% of that is coming from year-round island residents. We just announced another major gift a couple weeks ago in the paper from the Hackett's for $6 million. What is our affiliate doing to help this effort? What is Mass General doing to help? They have contributed a $10 million matching grant to the community. They're also contributing substantial development costs to get us ready to get to construction. And another important way they're supporting us is with interest-free construction financing. So when we receive a pledge that's payable over 5 years, we can get that money right away to start construction interest-free through Mass General, which is a big benefit. And again, we're looking at our internal goal to get to meet our timeline of getting to 90% by September of this year. So we've come a long way. We have a lot of work to do, obviously, before September. What is our timeline to get there? Right now, as I showed you, we're in the schematic design phase. So we're finishing our designs and plans for the building and getting ready then to submit them to the different regulatory agencies that we're going to have to go to. By mid-2016, those designs will be completely finalized and priced out. As I mentioned, September is our goal to reach 90% fundraising of the $89 million. And hopefully in early 2017, with all the approvals that we have, construction will begin. And about a year of construction takes us to 2018, when we hope to have the building finished, the old building gone, and take occupancy of the new building. So, and the other piece of this that we'll be dealing with soon is the regulatory approval. So what do we need? What permission do we need? From the state, the Department of Public Health, we're going to need to do what's called a determination of need, which is a big filing that is reviewed by the Public Health Council, by the state. Locally, we'll be going to the Planning Board, as I mentioned, for the major site plan review. Historic District Commission will weigh in, and hopefully we'll be securing the certificate of appropriateness from them. So that's all upcoming in the next few months here, where you'll be hearing a lot more about the project, seeing how the plans have come to how we've finalized them, bringing them to for local review, as well as the state. So the next couple in the immediate horizon will be some events that are coming up for us. We have a Children's Health Fair and our Native Reunion coming up on March 20th, followed by, we're going to be kicking off the community campaign for the new hospital. On March 26th, we had an invite to the community that was published in the paper today. And that will be at 7 o'clock at the Chicken Box. We'll be showing some revised plans and talking about how people can get involved if they want to help us. And as always, the Boston Pops is in August. So that's kind of brings you to where we are today. We hope you, I'm sure you have some questions or comments. If you want to let us know now, by all means, or if you want to get in touch with us later, Brenda's door is always open. I'm always available to answer questions or talk about the new hospital. So please get in touch with us. And we've been running our biweekly ads in the paper talking about the project and putting out an email and phone number for people to call if they want to weigh in with any thoughts or questions. So please do, because this is our hospital and we have this sort of really once in a generation opportunity to do this and do it right. So we're trying to do that with the help of all of our community members and donors and staff. So thank you everyone for being here, and we appreciate you guys coming out.
Does anybody have any questions?
Thank you. That was an excellent presentation. Oh, should I use that? Yeah. Thank you for the presentation. I didn't notice on the plan if the MRI facility, is that moving inside and not using the vehicle anymore?
No, we are going to use the MRI trailer. It's going to be outside, but it's going to be tucked next to, you can see it right up there. Hopefully we can cover it up so that it doesn't look, so it looks like it's part of the building. Right now, it's a huge cost, and like I said, we will be digging down the, what do you call it, the parking lot, if you will, where it's trailered, so that you don't have to walk up and down stairs. You're going to open a door and you're going to feel like you're right there.
Yeah.
So
I think that was part of the considerations of, trying to stay within that budget that we've set for ourselves of looking at a fixed MRI inside the building versus what we have now. And I think it will be a lot different than what we have now. You're not going to have that feeling
Right.
of walking into a trailer, that it will feel like it's part of the building.
right.
Are there changes that are going to occur with Goodwin Village?
Yeah, so we have been in discussions with the Coast Guard and UMass Boston about that when we went through town meeting, and trying to create a separate entrance that will get sort of segregate off the Coast Guard and the UMass Boston properties. Let me see if I can pull that up on the town. Right, so if you look right here, this is Gwen Village, this is UMass Boston right here, and this is the hospital portion. And I think what you're going to see is this will have a separate entrance, and this will have another road that comes in that gets you access to family and children's, family planning, the people who are using that space now, and that this might be used. There's no definitive plans yet, but potentially this open space here during construction could be used for parking, because we know we're going to lose all the parking that we have now during construction in this area is going to be gone. So we're going to need to find a way, keep the patient parking right at the hospital, but find a place for employees to park. So that could be one use of Gwen Village in the immediate horizon.
And I just have some pedestrian safety concerns that I'll share with you afterwards. Thank you.
Thank you.
Okay.
Hi, Lucille Jordan. Perfect map for my question. The 3 outbuildings, obviously they have to be removed for construction, I assume.
Yes.
And where will the services that are currently, the doctors who are in that building, where do they go?
So logistically, I've actually been running around trying to figure out who's in what building and how much space they have and their requirements. We do have the ability to move people in Sherburne Commons, and we do have some property that we've rented from Dr. Qureshi on Bartlett Road there, where we can where we can put some physicians, and identifying people in the other offices like palliative care. I'm just using that as an example, and finance people. So we're trying, and the foundation. So we're trying to figure out where we can put those people in the interim until we've got a firm plan of moving the buildings. So that's number one on our hit parade right now. Oh, it is. It is.
Yeah, and
lots of consideration, lots of factors. Some people actually might be working from home that are appropriate. Yeah.
Right.
So we're working very hard on that right now.
You'll actually be seeing the Nantucket Cottage Hospital signs going up there soon at 4 Bartlett Road. That's just right near where Poets Corner. So that building will be an option, I think, for some of the physicians and other things that need to move once construction begins.
Hi, I've got an unanswerable question, but a case for consideration. Basically, dental and vision. American medicine treats those as add-ons. You have to get a separate insurance policy. Medicare doesn't cover. I'm not suggesting that the hospital take over the practices that are here, but when we consider the number of times that patients are referred off-island, is there a way that, and this is for consideration, you're not going to answer it now, is there a way that the hospital can be the coordinating facility for referrals, for grand rounds for the dentists and optometrists to stay up to date so that we can get as good care as possible?
Well, thank you for that. I think we'll take that back and mull it over. Thanks, Lee.
On what's going to be provided in the new hospital, I didn't see anything for hospice or palliative care, so I wondered if you could comment on that.
So we are not planning on having palliative care be in the building, but Charlene and I have spoken, and we're very clear that it's important for her. The majority of her work is outpatient. It's seeing patients out in the community. And so we're very clear, especially since she had a board meeting, I think, recently, and she said, I need an answer, that she needs to be close to the hospital so that she can interact with the physicians, use the respite room. So we're working on that still. Yeah. But we're very mindful of what her needs are for her department in order to support palliative care in the hospital.
Right, and I think that's one thing that we've looked at with a lot of different services is what needs to be in the building and what can be off-site. You know, I told you physical therapy is now gone. I think we went through a whole period of talking about dialysis. Does dialysis need to be in the hospital or can it be off-site? And what is the cost of keeping it in the building versus, you know, having an off-site location? So, and with the limited size of the site and the sort of how we had to shoehorn this building into the existing site with the new hospital running, you know, it created challenges in terms of what can go where, what can be next to each other. So this is something Brenda and the staff and the people and the community groups that have been part of this have been like racking their brains over, really trying to figure out what makes sense and what should go where and what needs to be in the hospital. And, you know, it's excuse me, it is going to be one building, but one thing that we went through was, in a way, to get the cost to where within the budget that we set. This is going to be actually the hospital built to the hospital construction grade, and this is actually going to be a different sort of level of construction, which is the physician offices, which don't need to be built to the hospital, you know, level steel frame. So it's going to be two buildings that will be one, but just different levels of construction, and that again helped get the project within the budget that it needed to be. Any other questions for us?
I presume there'll be a basement under all of it.
No basement. So we and this is a question that we get as well, where we've talked a lot about, and one of the considerations, right, is the hospitals and the lessons that came out of some of the recent Hurricane Katrina. Some of the hospitals, they use the basement space for the facilities, for generators, for a lot of the things that make the hospital run. And what was the first thing that happened when they had significant weather? Those hospitals went offline, and they had a major crisis when they had no power. So we did talk a lot about that. Does it make sense to have a basement? What would we use this space for? What is the additional cost to doing that, and what would be in there? So right now the plan, and again, to keep it within budget and knowing that we're going to put the facilities and the other infrastructure on the roof rather than in the basement, there's not planned to be a basement at this point.
Maybe I'm forgetting the layout of the hospital, but I thought the cafeteria was in the basement. Currently.
It's not. Presently, what's in the basement now is facilities, the medical records department, and environmental services. So the dietary is going to be on the second floor. So when you walk up the stairs, see that yellow area in the front? That's actually a walking hallway waiting area for patients. That's where the public would be versus staff mostly. But the dining room is in the blue, and it's quite nice actually there, because if you think about it, it serves the OB patients whose husbands or family members are waiting for the mothers to deliver. It also serves the operating room staff, infusion staff, so it's easy there. And it also serves the administrative rooms because there's 3, I don't know if you can see it, but there's 3 conference rooms, so we will continue to provide space to the community as we always have. But to bring food to those meetings is pretty difficult. So,
Food in hospitals is really important.
Right.
food
No, as you
and
saw,
lights and calm.
30,000 meals last year.
Yeah.
In 1 year alone.
Sure.
Well,
This is a hot topic, we know.
2 years ago, I was flown off to MGH for a pacemaker, and I spent a week at MGH, and it started an inadvertent weight loss program because the food was so disgusting, I couldn't eat it. So the food at Nantucket Cottage Hospital is really very, very good.
They do a great job, thank you. Yeah, our staff really it's important to them that the patients and the staff have great meals, and they do a really, really great job.
I think one of our challenges is to think about what is healthcare going to look like in 5 years, in 10 years. Right now, we're in the midst of a huge electronic health record project where in 2017, we will be entirely on the EPIC system, which will be part of the entire partner system, and electronic health records is where we're going to go. So we're so used to paper, and we're so used to, hand delivering something to the volunteer desk so that we can get our lab done, and that will all be done through technology, and our roles will be changing. The person that's been scanning something, because that's what we do, we may not be scanning things in 5 or 10 years. So we're really trying hard to be as proactive and be as thoughtful as to what our jobs are going to look like down
Right.
the road,
Yeah,
because it's just not the same.
Right, and we've talked about things like, what is registration going to, right now we have all this space for registration in the hospital. What is that going to look like in 5 years? Are people going to be registering themselves on their phones at home and going directly to the room in the hospital where they need to go? How is that going to change? Are we going to have kiosks instead of someone waiting there where you can, if you want to, you can go and register on the kiosk there, or you can go and talk to Jerry and the blue coats that are there. So all those factors, and again, this has been such an exercise in trying to find the right fit. Not too big, not too small, crunching the numbers, how many, what's our patient census, how many primary care visits do we have, how many inpatients do we have, and really, not overbuilding, but not underbuilding either. So that's been something that Brenda and her team have really struggled with, but we think we've got the right answers now, and looking at, the births, how many, sometimes we have 130 births a year, so over 365 days, that some of the time, that it's going to be empty. But sometimes, you could have six women in there laboring.
We might have 70% of the time, we might have less than 3 mothers in the labor and delivery area. So that's a lot of time. There are days when we don't have anybody. So you have to figure out what the balance is.
Right, and again, that goes to having these rooms being multifunction. The emergency room in the summer versus what the emergency room is in January, February, March is a very different place. So again, trying to get this building that makes sense, that works for Nantucket, works for the seasonality, not too big, not too small, not underbuilt, not overbuilt. So that's our task that we're going through now.
Well, let's give them a round of applause for such an informative food for thought. Thank you, Jason and Brenda, for a fabulous presentation. I want to thank you all for coming again. Next week, we'll have Fran Cartoonin here talking about slavery and abolition on Nantucket, and that will be in conjunction with One Book, One Island. So we hope to see you back next week.